This lesson will cover what an evidence-based model of care is and how a RN provides the care to My Choice participants. The objectives for this lesson are to have the knowledge and skills to provide an evidence-based model of care, to review the assessment, person-centered service planning, and care processes. We'll then present a case study. Within the evidence-based care model, there are 4 phases of RN care: assessment, with the participant, the situation, the home environment, and also readiness to change. On the My Choice IHC, assess rather than just check boxes on the assessment using self-report and observation. Focus on underlying issues that impact function and identify problem performance, particularly areas to understand their abilities, preferences, desires, and needs. Focus on nutrition, pain, mood, medication review and management, fall prevention and getting up after a fall, communication with healthcare providers, and incontinence. On the person-centered service plan, problem solve and collaborate with other team members and the participant to develop a plan and expected goals and outcomes. And then enact the plan, and once it's underway, evaluate if the strategies selected by the participant are effective or not. Remember to role model enactment of strategies so that when you're not in the home, the participant or caregiver know what to do. And then you also evaluate if the strategy is working or not, because sometimes we have to modify a strategy or select a new one if it's simply not working. So the focus of RN care shifts from disease processes to how the disease affects function on a day-to-day basis and targets participants' underlying issues that influence physical function. This includes use of the evidence-based information regarding strategies to resolve issues, such as pain management or communicating effectively. RNs no longer tell a participant what to do, like in the medical model, but we ask, what are your desires and needs, and how can I help you achieve them? This is using the new evidence-based model of care. Here's our first checkpoint. True or false? The RN focus of care shifts from disease processes to how disease affects function. The answer to this is true. We shift focusing on not the disease process, but how the disease affects function. Remember, you're going to begin to assess readiness to change to understand if the participant wants to change or not, and what phase of change they might be in. This will help you to understand if a participant is actually ready to change so that you know if you should expend your energy there or not. So first you assess yes or no. Are they ready to change? If they're in pre-contemplation, that means no, they're not really thinking about a change at all. But if they're in contemplation, that means they're considering trying. But if they indicate a willingness or wanting to try something different, they might be in the preparation phase, or they might be in the action maintenance phase. It'll only take you less than 2 minutes to conduct a readiness to change assessment, and this will help you better understand where to focus your energies with the participant in areas where they really want to seek improvement. So here's the focus of care for the registered nurse. The first one is medication review and management. Medications are a significant problem for My Choice participants, as they can be taking between 10 to 48 medications, which can cause a lot of problems with interactions, and sometimes they even cause illness. So currently in the My Choice program, medication review means listing the medications taken in the record. This is usually the prescribed, over-the-counter, and other medications, but it doesn't usually involve management of medications. So if the participant is on 7 or more medications, or have medications that you feel can cause dizziness or be contraindicated because they're an older adult and might be at risk of falls, or if you think they might have polypharmacy, then medication management is needed. That means when you manage the medications, that you think about providing information and teaching them to self-manage medications. What are the correct drugs, doses, times, and reason taken? And do they increase fall risk? Are they NSAIDs? Because they're not to be used in people over 60, and they should be trying Tylenol instead. Do they use a medication list, a log, or container to organize their medications? And do they bring a list of their medications when they go to see their PCP? Do they question every new medication to see if they really need it, are they going to use it, and does it interact with their current medications being taken? And new is assessing interactions and making a plan to modify the medication list if it is needed. We'll provide 2 additional lessons on medication management to help you do this. So here's another checkpoint. True or false? Medication review and management is part of care. The correct answer to this is true. You'll be reviewing, but you'll also be managing the medications. You'll also, as an RN, be focusing on balance and strength improvement. So this is important because it's a strategy that helps a participant in many areas: fall prevention, mood improvement, and pain reduction. Activity has also been proven to build strength and balance to prevent falls. So the RN might review and demonstrate medications on balance and strength, or chair exercises, or Tai Chi. That means you would provide activity handouts to the participant, and then more than likely demonstrate how to do an activity and practice together with the participant. You'd be simultaneously assessing the participant tolerance, weakness, pain, and fatigue, and then adjust the activity regimen according to the participant's capability, needs, and wishes. Some participants do not want to do the activities. However, use of motivational interviewing has worked with engaging older disabled adults to actively pursue improving their balance and strength. So the goal is to encourage the participant to remain active at whatever level of ability they have. Another area of focus is fall prevention. It's extremely important because 30% of the older adults fall and often have repeated falls. We all know this because you work in the My Choice program already. So things in a home that can be a problem are railing, steps, rugs, floor condition, bathroom or bedroom area particularly, and lighting or clutter. Within this program, the OT will examine the environment and observe the participant in the setting. But the RN will also review the CDC, check for safety, which is in our Aging in Place toolkit, which you will be seeing shortly. And then you'll be taking action if needed. You'll think about how to discuss fall recovery with a participant. You'll review the How to Get Up from a Fall in the Aging in Place toolkit and demonstrate how to get up from a fall, and have the participant return the demonstration if possible. You'll also be managing dizziness. It's very common in older adults or those who are disabled. If a participant experiences dizziness, you'll do the following. You'll explain what it is, feeling faint, woozy, weak, or unsteady, and what vertigo is, a person or room feeling like it's spinning or moving, and what can occur, making it difficult to walk or feel off balance or disoriented. And then discuss the possible causes of dizziness: dehydration, changing positions quickly, low blood pressure or low blood sugar. Sometimes certain medications have side effects of dizziness. And some conditions like a stroke, head injury, or ear infection or other ear problems and anxiety can cause dizziness. Then you need to help the participant understand how to care for themselves, that they need to drink fluids to prevent dehydration every day. They need to change positions slowly, from lying to sitting or sitting to standing, so the body has time to adjust. They need to manage their medications and eat regular small meals to keep their blood sugar steady. And you need to cover with them when to call 911 If they have a sudden severe headache or neck pain, a head injury or seizure, or new confusion or trouble understanding speech, or a sudden change in speech or vision or hearing. Or if they have numbness or weakness of the face, arms, or legs, and a new inability to stand. Or if there are unequal pupils or drooping eyelids on one side, or new clumsiness or a tremor. Or, of course, if they have chest pain, irregular heart rate, or shortness of breath. And then you help them identify strategies that may work for that participant to reduce the dizziness. You also focus on managing pain. Here is a picture of the World Health Organization pain ladder. I think you already know that over 80% of the participants in the My Choice program experience pain. So a pain management rule of thumb is to start low and go slow with medications. That means there's different levels or approaches with mild pain, moderate pain, and severe pain, both with type of medication that should be used and the alternative types of pain reduction interventions. So aging affects medication use. This is important because it reduces GI absorption, and they have increased fat to lean body ratio, poorer liver metabolism because it slows, and their renal excretion is decreased. This is very important to know when prescribing pain medications. We also know that there's a lot of barriers to pain management: lack of knowledge, fear of addiction, and adherence to the medication regimen. So here are some suggested pain management options. Use acetaminophen or Tylenol as first-line therapy. And also always try alternatives, which can include relaxation, distraction, acupressure, massage, music, pets, yoga, healing touch, hot baths, or walking exercises. You can see other strategies in the toolkit. You'll also be managing incontinence, which is the loss of bladder control. Causes of incontinence are drinking alcohol, caffeine, or carbonated soft drinks using artificial sweeteners that irritate the bladder, or taking heart and blood pressure medications, sedatives, or muscle relaxants. It's simply due to aging, with an enlarged prostate in men and sometimes menopause in women. Within our Aging in Place toolkit, you'll see several strategies that can be attempted to reduce incontinence with participants. Here's a short list of these items. You need to prevent constipation by eating more fruits, vegetables, and higher fiber and cereal, as the belly presses on the bladder and can block urination. Try drinking more water. It helps control how often you urinate, and cutting back on caffeinated drinks also helps. And then suggesting tinkle before you sprinkle every 2 to 3 hours, or wearing an incontinence pad or brief if needed. Always urinating before leaving the house, and practicing pelvic muscle exercises. And they always need to avoid bladder infection by wiping the bottom from front to back after using the toilet. The RNs will also be managing memory issues. Forgetfulness is a normal part of aging. As you get older, changes occur in the brain. There's mild forgetfulness, and there's also dementia, which is a mental processes disorder with memory and personality changes and impaired reasoning. But there's also Alzheimer's, which slowly destroys the memory and thinking skills and eventually the ability to carry out the simplest tasks. It often begins slow and gets worse over time. Causes of memory issues can be medical problems from medication and liver or kidney problems, or it can be emotional problems such as stress, anxiety, or depression, which usually goes away when it fades. But I think most of us know a lot of the disabled and older adults have both medical problems and emotional problems. So here's a few tips to maintain memory for participants. Engage in physical activity and exercise. Plan your tasks. Make a to-do list and use memory aids. Develop interests or hobbies. Do mind exercises. Limit alcohol use and do not smoke. Get enough sleep and enjoy enough fruits and vegetables. We're providing an Aging in Place toolkit which has 12 of the most aging issues within it and strategies that participants can try, most of which are interventions that do not need to be prescribed by the PCP. These strategies can be used to ease the problem. We also have information sheets on other aging in place topics that are less prevalent. We have a lesson coming up in the future to review these items. We'll also be providing what's called a passport so that the participant can write down notes in it to guide their discussion with PCP. It's information that's evidence-based, and we provide it to the participants to support their independence. It organizes their health information in one place, and it allows them to take an active role in their health. And it has been demonstrated that this facilitates communication with their PCP as well as the other multiple healthcare providers they may be interacting with. So here's a case study of a real-life My Choice participant who received this evidence-based model of care in our pilot study. Case 1 is a 45-year-old female who lived with her mother in a trailer, had anxiety, atherosclerotic heart disease, COPD, GERD, CHF, hyperlipidemia, depression, morbid obesity, and diabetes, and a stroke in 2011. Her desires were to improve her strength and balance from her stroke and the morbid obesity, improve her ADLs and IADLs, and remain as independent as possible, living at home and not in the nursing home. The RN coordinated with the OT and the participant to increase her strength and flexibility, doing exercises 3 times a week. There was a lot of interdisciplinary coordination, and they all used motivational interviewing. They helped the participant to feel more secure and protected from accidents, building her self-efficacy. The RN provided information needed on how to hold on to the furniture to ambulate, which was person-centered, self-directed care. And all of the team members and the participants built a relationship, which allowed the participant to vent her feelings. They also used cognitive behavioral therapy. They arranged for support for weekly hygiene care and encouraged her to use the removable shower head to improve her hygiene. So they were demonstrating role modeling. The participants stated, "Sometimes people come in my home and they don't help with anything. You did." This demonstrated the person-centered, self-directed care. She also said, "I think the instruction that you gave me provided the confidence to go ahead and do things that I hadn't tried in a long time." So using motivational interviewing and cognitive behavioral therapy, they were able to build her self-efficacy. And here's another case. The RN, the history was a 64-year-old female who lived with her husband in a home, and she had a traumatic brain injury as a result of a vehicle accident. She had seizures, hypertension, arthritis, and pain. Her desire was to increase her functional ability and resume activities of interest from before her accident, like gardening, reading, and going on outings with her husbands and friends. Building a relationship, the RN used cognitive behavioral therapy, talking points, to identify doable improvements. The person-centered service plan included interest in the exercise program. So they worked out a calendar designed with therapy days and rest days, and which exercises could be done at home, with a list of pain modalities to use prior to starting the exercises. For this, the RN used motivational interviewing and role modeling. The RN also reviewed the medications and provided updated medication information lists and encouraged the participant through motivational interviewing to discuss any issues noted regarding side effects like dizziness with her provider, building her self-efficacy and helping her to use the health passport. The RN also provided information needed to change the position slowly from lying to sitting and sitting to standing using a 30-second rule, prior to changing positions and to use her cane or walker as needed. The RN used role modeling to build her self-efficacy. And then regarding the intimacy difficulty after the accident due to limited flexibility and pain, the RN provided information on various positions and techniques to trial and on positioning devices, as well as where to purchase them, so she would be able to position comfortably and increase her ability to have intimate relations with her husband. She did this through building a relationship. The participants stated, "The program is good and has many good ideas. They really listened and tried to help me. This demonstrated how this person-centered, self-directed care plan met the needs of the participant." And here's another case. This is an 89-year-old female who lived alone in an apartment and had CHF, peripheral vascular disease, diabetes, neuropathy, depression, and anxiety, and hypertension. Her desire was to be able to bathe, wash dishes, make meals, and visit others once weekly outside the home. Building a relationship was the RN's first issue, and after 2 home visits, the participant designed a plan. The RN used cognitive behavioral talk therapy with the participant to help her identify doable ways of improving physical function to remain living in her home, and they jointly designed the person-centered service plan. The RN used motivational interviewing to get the participant to allow aides to assist her out of the home, building her self-efficacy, so she could have social activity at a senior center, go to doctor's appointments, and shop. The RN also used motivational interviewing to help the participant to conduct an exercise program to build her strength and reduce her fall risk. The outcome was acceptance of assistance to leave the home weekly and to socialize. The participant stated, "I am much happier now that I am getting out of the house than I ever would have been without your help. Bless you." So in summary, evidence-based RN care includes use of these types of principles, techniques, and approaches that you have learned about over the last few modules. You assess what the participants' needs are and identify their desires after listening intently. You co-design a person-centered service plan with the other clinicians and the participant, tailoring to the individual's needs and helping the participant select strategies to meet those needs. And then leading care, you help the participant enact the strategies and evaluate if they're effective or need to be modified. And the end result is you support the participant to live in the community and improve their quality of life. Thank you.